Hello, we are the AlgorGriffins, Mathical creatures representing the College of William and Mary in the 2023 Virginia Datathon, and we're presenting our data-driven insights and solutions on mitigating maternal mortality in Virginia. Our team consists of Grace Cavaco, Josh Spicer, Shirley Bergstrom, Madhvi Kapadia, and Jennifer Karnowski. Our analysis sought to answer the question, what significant factors contribute or drive the increase in maternal mortality in Virginia, and what can we do to mitigate risk using solutions based on data insights? Using large data sets from the Virginia Open Data Portal, we used XGBoost model, decision trees, Tableau visualization, and report analytics to determine factors that contribute to the increase in maternal mortality. We found through analysis that race, health district, health region, average labor and delivery charges, diagnosis, and maternity level of care were parameters of interest. We also analyzed known determinative factors from the Department of Medical Assistance Services to build upon mitigative solutions. Overall, we found that access to care, prevention education, as well as data availability all had the underlying commonality of socioeconomic inequity. As a result, we chose to create innovative solutions to address this imbalance. Here we show a map of Virginia counties organized by VDH health districts representing levels of maternal deaths per 100,000 residents and maternal care level. Unsurprisingly, areas with poor access to care show higher rates of maternal death. So how do we increase access to care? We came up with several ideas that, if implemented, would decrease many of the predictive factors leading to maternal mortality. The first is telehealth. Implementing telehealth programs that allow patients to connect with healthcare providers remotely is particularly helpful for individuals in rural areas who may not have easy access to healthcare facilities. Likewise, community health centers would help to mitigate this problem. Investing in community health centers that provide primary care, dental care, and other services to underserved populations is a less expensive option than establishing hospitals or traditional medical facilities while still providing access to care. Utilizing other public services like libraries or schools to establish telehealth centers may help in situations where many lower income communities may not have access to quality internet. To reach these populations, we suggest partnering with other public services to establish telephonic and dedicated computers with private pods or rooms that mothers could use to receive care without the concern of transportation, personal connectivity, or negative community stigma. Another idea is to create practitioner incentive programs. Virginia could allocate funding to programs that agree to train and license nurse practitioners and physician assistants in exchange for a term of service in underserved areas. Additionally, a program seeking to alleviate student loan debt for OBGYN residents could incentivize providers to practice in remote or rural areas for a dedicated period of time. If other centers are infeasible, mobile health clinics that travel to underserved areas and provide basic medical care to patients who may not be able to travel to healthcare facilities would allow providers to care in underserved areas without residing in the region. All of these solutions address our next finding as well. This visual shows average total labor and delivery charges for mothers between the years 2018 and 2022 broken down by patient race. The trend shows that overall care costs have been increasing at a fast pace in the last 5 years. Additionally, Black mothers have notably higher healthcare costs. We can interpret these findings to indicate that emergency intervention occurs at a higher rate for mothers of color. We determined that this correlates highly with quality patient medical data and access to prenatal care. Providers are more likely to intervene with emergency cesarean sections in order to protect the health of the child if the medical status of the mother is unknown. By increasing access to care, using our solutions, we facilitate pre- and postnatal care in a formal but non-traditional setting, which allows for patient-level records and medical history gathering, leading to better data availability and quality. We also noted that we needed more access to data pertaining to births that occur outside of the hospital setting. In a huge win for Medicaid expansion, the Commonwealth of Virginia approved a policy permitting a 12-month supply of contraceptives to increase health equity and reduce unintended pregnancies. We would like to build on that win. So many prescription services today are available through an online intake form and a 5-minute telehealth call. We'd love to see that methodology extended to contraceptives and the delivery of contraceptives. If transportation is a limiting factor to the proper use of birth control, we could see this corrected through at-home delivery. Additionally, knowledge about the proper use and entitlements should be available in multiple languages so that women of color are not left behind. We believe if our solutions are implemented, we would see a stagnation and eventual decrease in the rising maternal mortality rates due to socioeconomic inequity. The proliferation of these services would lessen the consequences of poor access to care and will allow for iterative improvements within social programs. Thank you for your time and for the opportunity to make a difference for our mothers and, in turn, the next generation of individuals seeking positive change.